Hey everybody, welcome to Medics for Ethics' first episode of The Doctor's Dilemma. Today I want to talk to you about the Groningen Protocol and some ethical concerns that Alexander A. Kahn, our author for today, brings up in his 2008 article. But wait, before we get into Kahn's argument, you're probably wondering, what even is the Groningen Protocol? The Groningen Protocol was created to allow physicians to perform active neonatal euthanasia without fear of prosecution. Some basic requirements are that the parents must initiate, consent to, and make the final decision about termination of their child's life. The child must be under age 1, and doctors and social workers must consult with the parents before termination. According to Kahn, the protocol was made to address a serious problem in neonatal care, the use of invasive life-prolonging interventions, such as cardiac surgery, for infants who are greatly suffering but not terminally ill. Some children have very little chance of living past these intense procedures. Others live, but have a very, very low quality of life. For example, infants born with spina bifida, a condition known to inflict intense suffering, have already been euthanized under the Groningen Protocol. But is the Groningen Protocol acceptable? Kahn says no. Kahn has two arguments against the Groningen Protocol. In the first, he emphasizes that infants can't give informed consent, and that adults are unreliable judges of how unbearable an infant's suffering is. The uncertainty of how much a child may be suffering leads to a second argument, where he says it's safer to reject the Groningen Protocol altogether, since it could lead to ending lives that would have been worth living. He also highlights that a core ethical principle of the medical profession is to do no harm, and this protocol may inadvertently cross that line. Let's walk through the first argument. The first concern Kahn addresses is that of informed consent. He points out that infants cannot comprehend facts, express their wishes, or judge what's in their best interest. They can't give consent. And worse, they can't communicate at all. Kahn states that overwhelming data suggests that parents, healthcare providers, and the general public often overestimate the suffering associated with serious medical disabilities. Parents' judgment is likely to be even more unreliable. They don't want their kids to suffer. A quick example, spina bifida, the condition I spoke of earlier, is often associated with unbearable pain. But according to WebMD, 90% of babies who have this defect live to be adults, and most go on to live full lives. So Kahn concludes that we can't base any decisions off the unbearableness of an infant's suffering. It's too risky. They might have a nice life. Now let's take a look at the second argument. Do no harm, the Hippocratic Oath. The harm Kahn is most concerned about is killing. In the case of the Groningen Protocol, killing would be terminating a child's life where the benefits of being alive outweigh burdens of suffering. As we determined in the last argument, it's pretty hard to accurately identify which infants would benefit from the Groningen Protocol. But Kahn points out that killing an infant whose life is worth living may be the greatest harm a physician could inflict on a patient, and we shouldn't allow any possibility of causing such a harm. So Kahn thinks that we shouldn't accept any protocol at all that actively terminates an infant who is not dying or terminally ill, because it's better to be safe than sorry. So, what do we make of the Groningen Protocol? I want to provide some backup for Kahn's first argument. When he discussed pediatric nudges, one of the first costs that we considered was the violation of autonomy. Whose? The parents'. The author Mark Navin argued that parents' autonomy is worth less than the patient's, and the physician's primary duty is to the patient, in this case the child. Applying this to the Groningen Protocol, we see that the physician may have a duty to outright deny a parent's wish to terminate to protect their child's autonomy, since the child has no say themselves. Let's take a look at the support Kahn gave for the first argument. We saw the problem of informed consent when we discussed incompetent patients. Timothy E. Quill brought up concerns about active euthanasia. To recap, Quill believes active euthanasia is okay for normal adult patients who meet certain requirements, but he thinks it poses risks for incompetent patients, specifically abuse of power. Like Kahn, he's concerned that a caregiver's judgment is unreliable. It may not be in the best interest of a patient whose autonomy is hindered. But if the Groningen Protocol is unacceptable, then what should we do? Kahn offers some solutions, but they don't really solve the problem the Groningen Protocol was meant to address. As an alternative to the Groningen Protocol, Kahn's plan is to provide these kids with the best medical care possible to minimize the suffering, and then reassess in later years if the child communicates that their suffering is unbearable. And if the child is cognitively impaired, VAE is not an option. But although Kahn's solution seems safer than the Groningen Protocol, it doesn't address the original problem. And it has ethical implications of its own, though they may not be as severe. Khan's solution asks children to live with possibly unbearable conditions for a long period of time, and then initiate life or death decisions. So the question still remains, if not the Groningen protocol, then what should we do? Thanks for watching.